Just a little bit about me. So I'm a seventh year medical student in UISS. I'm deeply passionate about medicine and dedicated to helping others. Also, I have some certificates and accomplishments that I've cited here. So if you have any question about how I did it, you can just message me and I will tell you how exactly. And I hope that your medical career will not be all about medical studies. I hope that you give from your time for your personal development and doing other things that will make you a better person. But of course, the studying will come first. So here we are. Are you ready to dive into today's case? You can just type whatever response you want, and I can see it. Okay. Well, I love the excitement, absolutely. You just think so? Okay. I think we'll just begin. So this is just a taster so that you can get used to what's coming. So let's start. So this is today's case. Our patient have 42 years old. So for these symptoms, she has unilateral right nipple discharge occurring spontaneously at 8 o'clock. So it's here. And it's seroematic in nature. I will let you just 1 minute to read the case, and then we will go into the questions. So now let's start. Okay, here is the first question. We have 6 questions. For those who want to join, they can just go to menti.com and then enter the code so that they can be here with us. Okay, we have 3 players for now. So I hope that will be more who will join us, because it will be fun and nobody can see who is voting. So it's anonymous, as I've told you. Okay, now we have 3 players and it's already enough. So if someone wants to join, they can just go to menti.com and then join after this. Okay, so this is the first question. So what is the correct assessment for this case? Is this a physiological discharge or is it a pathological one? Okay, so everyone has voted. That was quick, and those are good answers. Okay, now let's see who voted first. So, okay, so Iman was the fastest one. But everyone obviously voted right, so that's a good thing. And so now, this is just a small conclusion. So we have a 42-year-old with a spontaneous seroematic nipple discharge from a single duct, and the discharge is considered pathological. So now here we have just a pic that show us the different discharge and what can it give us as diagnosis to think of. So here we have a white clear or cloudy discharge. It's most likely just for cause of breastfeeding or galactorrhea or hypothyroidism or prolactinoma. And here there is the yellow discharge, as you can see. So it's most likely due to hormonal fluctuations or an infection. And here is it the green, brown, or black discharge. Here you can think of the duct ectasia or the intraductal papilloma. And for the red, pink, or bloody one, like this case, you can think of intraductal papilloma or breast cancer because it's pathological. And here is the second question. Okay. I've just seen the Revo BNG asking question that she can't enter here. Yes, you can just answer in the message section, and we will see who will be the winner at the end. Okay, so here is the question. What aspects of the patient history is most critical to determine in case of nipple discharge? Is it the recent changes in medication, history of breast cancer, duration and onset of the discharge, or all of the above? Okay. So we have two answers who voted all of the above and one history of breast cancer in the family. So it's yes or no. Yes, it is a history of breast cancer. You will ask about the history of breast cancer, but you should ask about the other ones too. Okay. Now Clostridium is the first one. So here's the explanation. A comprehensive history including medication changes, family history of breast cancer, and the characteristic of the discharge, duration, onset is crucial for determining the underlying cause. So you should just ask whatever you can so that you can have enough information on the patient to determine the diagnosis and to determine the cause. So here is the third question. Let's wait for the third player. Okay. Now let's start. I don't know where is the third player, but let's start. Answer fast. What color descriptor of nipple discharge is most concerning for malignancy? Okay. So all the two answered bloody. Yes, it is correct. Okay, let's see. I don't know where Clostridium is. I hope that he come back so that he can regain his place, his first place. Okay, that's good. Iman now is first, and Yasin was the fastest. So the explanation, the bloody or serohepatic discharge is most concerning for malignancy, necessitating further diagnostic investigation to rule out conditions such as intraductal papilloma or breast cancer, as we've seen in the picture shown first. So there was the bloody discharge and there was breast cancer and intraductal papilloma written in it so that you can think of when you see a bloody discharge. Here is it again so that you can just remember it. So red, pink, or bloody, think of intraductal papilloma or breast cancer. Of course, this is just a small conclusion so that you can remember the case. So this is the fourth question. Okay, Clostridium is back. So answer fast to get more points. For Samia and Revo, try to re-enter the menti.com and then enter the code. And if it's not working, I will try to write you the questions. But I think it's best that we see you in the application so that we can know who is the fastest to answer. Okay. Okay, now Iman is the first one, and Yasin the second, then Clostridium. Okay. It's always, this board is always changing. So the answer is diagnostic mammogram followed by breast ultrasound if needed. So what we need to do is do the diagnostic mammogram as we've said. Why? Because it's the first line imaging modalities for patients above 30 years old with suspicious nipple discharge. And it should be followed by an ultrasound to further evaluate any abnormalities detected on the mammogram. Okay, thank you for liking. In case of pathological discharge, we've talked about the smear tests, but it's not routinely recommended in clinical practice. Smear test is taking the discharge and then seeing what it is and going into doing the tests. Then we have the mammography, which is the first line imaging, but has low sensitivity, 20 to 25%. A negative mammogram does not rule out underlying pathology. And after this, there is the ultrasound. It is performed immediately after mammography. It has better sensitivity for detecting intraductal lesions. So the sensitivity is 65%, which is really good. So it should be done, the two, mammogram and ultrasound. And here is the mammogram of the patient. And as you can see, it's difficult to determine what this is, but we can see something here, but still we can't really tell what is the diagnosis. Okay, let's see the other one. Of course, this air for right and this is left, and you can see here the mammogram of the patient. And this is the ultrasound that the patient did. So you can see here enlargements of the ducts. So now let's go to the next slide. So as you can see here, there is a galactophoric ectasia defined by a duct diameter superior than 3 millimeters, and sonolucent consent should not be reassuring as it's observed in half of the papillomas and in 14% of intraductal carcinomas. So this is not reassuring image. So that's why we have to do further examination. Okay, we have our 3 players here. Okay, mammography plus ultrasound. That's good. Revo BNG. Okay, now let's go to the question. What would you propose for the following scenario? Fine needle aspiration, biopsy, galactrography, galacto-MRI, pyramidectomy. Which one would you choose? after doing the mammography and the ultrasound. Yes, it's the galacto MRI. The biopsy, yes, but not now, because for us, the ultrasound and mammography was negative. So the patient should do the galacto MRI and then do further examinations. Okay, so Yasin was the fastest. And he was the only one who answered right. But that's good. Like the three of you are answering really good. The galactography, previously the preferred method in the diagnosis process, it is invasive, often difficult, incomplete, or impossible to perform. That is why it is no longer indicated due to 20% false negatives. Topographic galactography performed in some centers, so it's not always performed. Previously it was, but now they do galacto MRI, not the galactography. For the galacto MRI, it has excellent sensitivity, 88 to 95%. Negative predictive value at 90% does not complete rule out of malignant lesions, and its limitation is the increased frequency of detecting additional image, so it can give you false positives, and it's currently performed in most centers for unexplained discharge by conventional imaging. So if they have a patient and they can determine why she's having an abnormal discharges, they do a galacto MRI. Okay, so now as you can see, here is the galacto MRI. Here you can see the duct. This is a lesion. So here is a bigger picture for you to see. The galacto MRI, so this is the galacto MRI, the lesion near the areola. So this is the areola, it's near the areola, detected at 8 o'clock, 2 centimeters from the nipple, in contact with dilated galactographic duct, ACR4. It's classified ACR4. Now, the final question. Okay. What do you propose? After doing the MRI, what will you do? Okay. That's right. That was quick. And all of you were right. MRI guided biopsy. No, it's microbiopsy or microbiopsy guided by ultrasound. We'll come back to the ultrasound after doing the MRI. Okay, so now I see it first. Okay, again. So that's good. With 403,028 points. Iman was close, was really close. Next time I will add another question so that she can win. Okay, now let's continue. Ultrasound guided microbiopsy, they did it for the patient and they found a papilloma without signs of atypia. So here's our take-home message. So I found a picture that really conclude everything. So it's better than giving you another take-home message. So here, as you can see, if a patient has a nipple discharge, you will see if it is milky, colored, bilateral, non-spontaneous. So this is a good sign. You will just reassure your patient and do annual screening mammograph if superior than 40 years old. if it is bloody, clear, unilateral, spontaneous, then you will see the age of the patient. If she's above 30 years old, you will do a diagnostic mammogram with tomosynthesis, if you have it, of course. And then you will see if it is negative or positive. If you can't find something in a diagnostic mammogram, you will do a breast ultrasound. And then if it is still negative, you will do an MRI with and without contrast, as it was the case of our patient. If it is positive, then you can just go do an image-guided biopsy directly. So this just really conclude everything that we've talked about, and it will just guide you to do whatever is necessary for the patient. And I think that's a really important subject, because I remember in one of our clinics, we had this question of what would you do if a patient come to you with a bloody discharge and it is unilateral. And unfortunately, most of the medical student didn't know what to say and what to do. So I hope that this added something to your information today. And if you have the same question that we had one day, I hope that you will be able to answer it and have this picture in your mind so that it's going to guide you. And as we conclude, I want to extend my heartfelt gratitude to the two remarkable mentors who helped me in this presentation, especially with the images and seeing if it's good for the medical students. Dr. Nadia Sqali Husseini, she's a professor, and Dr. Asma Sqali Husseini. And here is the form. So I hope that you click on it, and I want to see your feedback, because it really helped me improve and do better presentations for all of you. So you can just say whatever you want in it, and it will be so helpful for me. Thank you. And of course, precision in diagnosis breeds precision in treatments. So I appreciate your engagement today. Thank you for being such an excellent audience.